Hello, my name is Dr. Rajendra Prasad. I'm a senior consultant neurosurgeon and spine surgeon at Indraprasth Apollo Hospital, New Delhi. I have a particular interest in neuro rehabilitation, and hence, this first podcast on neuro rehabilitation is with a world renowned figure in rehabilitation medicine and, in particular, neuro rehab. So, I'd like to welcome you, Professor Dr. Steve Flanagan from NYU. Can you tell us a little bit about your background in neuro rehab and where you work? And then we'll go in from there.
Well, Dr. Prasad, first of all, thank you so much for hosting me today at Apollo Hospital. I've been here years ago, and I'm delighted to be back again as your guest. And to see how rehab has advanced in India, particularly here in Delhi and Apollo Hospital. My interest in medicine in general was really focused on brain and behavior. That's what I studied when I was in college, at undergraduate. And I thought I would be a psychiatrist or a neurologist, but I also like long-term follow-up of patients. So I thought maybe family medicine. And it wasn't until my third year of medical school when I found physical medicine and rehabilitation, which combined all of those things together. And more than neurology, where the neurologists are just so good at diagnosing and providing acute treatment, it's the physiatrist that follows these patients over the long term. And that's what attracted me. So that's how I got into it. And I've never looked back.
That was years and years ago, obviously.
Yes, indeed. A long time ago, over 30 years ago.
So you mentioned that follow-up is important. So each of us, follow our own patients. But once they're out of town, it's difficult to stay connected. And as I said, in neurosurgery, where the patients with head or spine injuries, they also need other specialists. So I think as a physiatrist, you found that you could be the maestro conducting, that you decide who needs what and you can call upon them. So have you found this multidisciplinary system of working? Is that difficult where you work, or have you evolved a system where you know who to call for what? And do the patients accept that they come in to meet you and then you say go and meet X and go and meet Y and follow up? How does this multi-speciality involvement in rehab, is it important, and does it really work?
So that is a key component to the success of rehabilitation. In order for rehabilitation to work, it is a true team sport. I look at myself as the physiatrist, not as the manager of the team, but the team captain. I'm in there, I'm treating the patient, but I rely heavily on my colleagues in neurosurgery, in neurology, in all medical specialties, psychiatry, radiology, internal medicine, endocrinology, the list goes on, as well as my colleagues in the allied health fields, the nurses, the physical, occupational, speech therapists. We all work together. I'm lucky at my facility at NYU Langone Health in New York City, which is part of the NYU Grossman School of Medicine, to have a wonderful set of colleagues, not just the therapists, but I work closely with my friends and colleagues in neurology and neurosurgery like yourself. And none of us compete with each other. We recognize that in order to achieve the best outcomes in patients, we all have a role, we all contribute. No one tries to outdo the other person, and we just recognize the strengths that we have, bring them all together. But the real important component, members of the team, are the patient and the patient's loved ones. When you work together, the outcomes are always better.
And you have specialty clinics, obviously, when you've built up a large number of patients. The bladder ones can go to the bladder clinic. The others go to the plastic clinic. So you've evolved like that, I'm sure.
Yes.
Into subspecialty clinics for special group of patients.
So when I first started as a physiatrist, way back, and I started my training in the late 1980s.
Sorry to interrupt. Tell us, what is a physiatrist to start with?
So a physiatrist is my field. So you're a neurosurgeon. If you study neurology, you're a neurologist. A physiatrist is somebody who has done 3 years of formal training in physical medicine and rehabilitation after an internship year after you've completed medical school. So it is a recognized specialty by the American Board of Medical Specialties. Came into being in about the 1950s. So a relatively new specialty. So that's our field. And when I first started in this field, there were just a few subspecialties in physiatry. I was a neurorehabilitationist, specializing in brain injury specifically, others in spinal cord injury. Maybe we had some pediatric or just plain musculoskeletal a physiatrist. But now we touch all fields of medicine. We have oncological physiatrists, pain physiatrists, spine physiatrists, pediatric, geriatric, the list goes on and on.
So you're everywhere now.
Indeed.
You guys.
We touch all medical specialties.
Yes. How would you define neuro rehab? So I just wanted to go back a step. How would you define neuro rehabilitation? Is there a role? And how would you say to a patient who just had a stroke and said, you need neuro rehabilitation? They said, what? What are you talking about? So what in simple terms, what
So in rehabilitation, we deal with disability. And for neurorehabilitation, we deal with the disability and the medical problems that go along with neurological conditions.
So I'll keep interrupting if you don't mind. So that some words don't go unexplained. So if I had a head injury patient, he would have a hemiplegia or a weakness of one side. So you deal with disability. So there's a disease. And then at the end of that acute treatment, disability is, you're describing is what is the impairment? And you work on that. Is there a difference between impairment, disability? How would you?
They're all related terms. So the impairment would be, as you say, something like weakness on one side of the body that may occur from a stroke, or it may be weakness of the legs that may occur from someone who has a spinal cord injury. It may be the impairment in thinking, or what we call cognition. And what I do as a physiatrist is to address those impairments that are leading to a disability. The patient can't do what they were able to do before. We address that disability by providing therapies, doing our best to return motor function if we can. But if we can't, then we use adaptive or compensatory strategies with the goal of getting the patient back to what is important for them to do. Maybe not in the same way, but it brings them to a point of as much independence as they can possibly have.
So rehabilitation to get back to work, to get back to society, to be accepted in their family with minimal, shall we say, discomfort to other people without caregiving support. That would be the aim, and occasionally technology.
Absolutely right. Howard Rusk started the field of rehabilitation medicine back in the 1950s. He started my institution, and I don't think he could have phrased it any better than you just did.
No, thanks. So is there enough evidence-based? Like if a person says, as he comes out of hospital, like you saw a lady today. So if they say, fine, we'll take rehabilitation. Do you have evidence? What will I be like in 6 months or 3 months or 1 year? Do you have enough statistics to back what you're saying?
So we do have evidence that rehabilitation works, and rehabilitation exists at almost every hospital throughout.
How early should it start?
Excuse me?
How early should it start?
So, that is a great question. So, you think that, really ill people who are in the intensive care units couldn't possibly be ready for rehabilitation. We say, no, that's not true. And we have evidence to show that when we provide rehabilitation in the intensive care unit, people who are on breathing machines, who are on ventilators, who have intravenous lines and monitors, if we get them up and exercise them out of bed, they actually stay in the hospital for a less period of time, have fewer complications, leave the hospital healthier, and actually require fewer services even once they leave the hospital. That's the value of rehabilitation early on, even in a critically ill patient.
So you're saying if somebody is in ICU 2 days after a stroke, you can still start rehabilitation and the results are better if you've done that?
Absolutely. You have to individualize that therapy. The therapy may just be something as simple as sitting up in bed, but you also require the assistance and the buy-in of the intensivists, the doctors who are working in the intensive care unit. They need to decrease the sedation. Sedated patients can't participate in rehab.
So you work as a team. So do you find that that children respond better to rehab because of plasticity. What is, we hear this word neuroplasticity. What is that, and does it apply sort of, it works better with children than with adults and older adults?
So plasticity is the sense that the brain can remodel itself, almost at a molecular or cellular level, that permits the brain or the body to recover. So an arm or a leg that's weak can get better. So you mentioned, do children do better? And in fact, they may, because a child's brain is plastic, if you think about it. I use that term colloquially, meaning that it's not truly plastic. The brain has the consistency of formed jello. It's very soft. But they have the ability to adapt and learn better than adults. The problem, though, let's say in traumatic brain injury, is that as they get older, they may not develop the skills in the same way that somebody else will. So for children, we have to watch what happens as they get older.
So we don't give up just because, they said this is a serious injury in a child and he may not do well. You don't give up. You keep at it. It can be for years. So we were told when we were growing up in med school that 3 years, if you don't recover, make a recovery. But as we have a shared patient and we realize that even 15 years later, 20 years later, if you keep therapy, is that true? That if you keep speech therapy and cognitive therapy and physical therapy, the benefits would carry on. So we can say to family, would you say to family that carry on even if in 3 years there's not 100% recovery? Would you say that?
Well, yeah, there's a lot in that question that you just asked. So for sure, most of the motor recovery after a stroke or a brain injury occurs early on within the first few months, or let's say the first year, and it begins to plateau or even off after that. But it doesn't mean that it stops. And I think once you tell somebody that that's as far as you're going to go, that's the exact moment in time that they stop trying. And when you stop trying, you also begin to decline. So it's very important that patients continue to exercise on their own, follow through on the recommendation of their therapist, even if that therapy was years ago. But that's also why I follow them up regularly to make sure that there isn't that decline. And if there is, I'll be very quick to reinstate therapy. People can continue to improve if they can continue to try.
So how well connected are you? I mean, if they choose, I'm not getting better, I'm switching off, I'm not going to the hospital. Do you connect online? Do you actually, your team chase them and said, why are you not here for your appointment? Would you then connect online and what is there a role for tele-rehab? That was one of my later questions, but it's come up. So let me say that.
So first of all, I would say anybody who has a permanent disability, like a traumatic brain injury or spinal cord injury or what have you, or stroke, never gets discharged from my practice. And when they leave my office, I'm going to schedule a follow-up 2 months, 3 months, maybe even just a year. And we will make sure, we'll call so that they will come for their follow-up. So I think that's critical. And the idea there is that if there is a problem, and we consider something like traumatic brain injury a chronic condition, there may be some declines later on. So we want to catch that early and treat it. So that's very, very important.
So it may be a treatable condition like hydrocephalus. There may be counseling required for depression. There could be many reasons why they switch off.
That's exactly right.
When they do. But you've been around our hospital, and you can give your comments later. But in India, with 1 million people needing rehab every year, there's not so much technology available and not so enough hospital. Is there a lot can be done manually without machines? You're old school and you brought up. Yes, technology helps. Like when you said somebody that doesn't come to hospital, you connect maybe what VR, virtual reality training for motor skills and others. So tell us that there is a role for newer technology, but if it isn't there, it still can be done, right?
Yeah. So again, there's a lot in that question. So the best physical occupational therapy is done by a good physical or occupational therapist. Manually. So equipment is important. I don't want to suggest that it's not. But how that equipment is used is the skill of the therapist. So the most important equipment I recommend in any new rehab facility is good hands of an occupational, physical, and speech therapist. That's key. But technology helps. So I don't want to suggest that it doesn't. And I think that there's a big future for technology in rehabilitation and telemedicine as well.
Yeah. So if somebody isn't covered for insurance, so they are paying out of pocket, how do you keep them motivated over months, if not years? How how do you, in your practice, how do you keep them motivated? Because often they may lose that motivation to carry on. How do you do it? How do you handle it?
Yeah, so part of what we deal with in rehabilitation, particularly in my field in brain injury, are mood disorders. So that's one of the reasons why I treat people or I see people on follow-up regularly. And I'm always encouraging them to exercise. I hope that they come with family members. I encourage them also to promote ongoing exercises. And quite frankly, how does any of us get better over the course of time, whether you have a disability or not? It's exercise, it's challenging yourself physically and cognitively. That's how we all learn. Not everybody does it, but we do our best. And if there is depression, well, we may treat that.
Right. So like with yoga, like I wouldn't do it unless there was an instructor. Similarly, if you have a tele-rehab session lined up, there will be a therapist at the other end, and you will be forced to do it. Is there a role for VR? Like I'm seeing a lot of virtual reality and exercise that you do, and that seems to work in a way, both for cognition and for motor. So is there a role for VR? Do you use that?
So virtual reality is a very legitimate form of technology that's used to enhance rehabilitation, and it provides rehabilitation in a virtual environment that can be controlled. So you can teach someone to walk across a busy street, but it's really not a busy street. It's virtual, so it's safe, and that builds up confidence. So it's very helpful. But again, you still need the therapist there to make it work.
So there are a lot of controversy. This is something new, and we'll have to see how much positive response comes from that, or positive results. What about the controversies that surround certain therapies, like stem cell therapy, for instance? What is your view on that? And are there other similar controversial treatment that you would discourage? So let's start with stem cell therapy.
Yeah, so stem cells, I think, offer great potential in the future, but we're not there yet. We just have to face it. I think there's a lot of media attention that's given to it, and families have great hope that this is what's going to cure
particularly for spinal cord injuries. And we have inquiries from all over the world saying that if you started, or have you started it yet, so and so is doing it. So at your institute, do you encourage stem cell treatment?
So no, we don't, not for neurological purposes. It's still too early. It's still experimental. If there are legitimate trials, human trials that are safe and well controlled, I would not discourage somebody from doing it, but it has to be safe. But in my opinion, it is not ready for prime time, meaning that it is not ready for clinical, widespread clinical use at this time.
What would you say to governments in low-income and middle-income countries like India who haven't invested enough? There's enough for defense, there's enough for others, there's less for health. And in health, there's even less for rehabilitation. And you have, in US, worked it all out that so many man hours lost, so many dollars are lost. But in practice, we are not thinking of the wider picture, what happens to India and how many people are not back at work. So what would you say to governments that they're not invested enough in rehab facilities? What would you say that, how would you motivate a government department of rehab or whatever, that disability, what would you say to them?
So you need to look at the big picture. If you just take a look at a moment in time, rehabilitation costs money, and you have so many other areas that need to be worked on. But if you look at the big picture over time, the return on investment in rehabilitation is great. Just that example I gave of providing rehabilitation in the intensive care unit, it cuts down on the time that people are in the hospital, cuts down on the cost of the medications and the treatments you're providing. It saves money. There is a movement in America called the triple aim of medicine, which is to improve patient experience, improve patient outcomes, and to do it with less money. And it's my belief that in order to fully achieve that triple aim of medicine, rehabilitation is not a luxury, it's a necessity. It doesn't replace all the important things that you do as a neurosurgeon or what have you. But with all the good work you do as a neurosurgeon, what happens afterwards? You'll take out a tumor, or you'll, take some. Exactly right. But that patient then is left with a disability, an impairment. We'll address that and get them back to work. So if you look at the big picture, rehab is a bargain and will save you money.
Totally agree. What would you say to insurance companies in India who do not cover rehab? What would you say? And what is the American model for getting insurance to pay for your rehab?
Well, the model in America is very confusing and vast, and it all depends on the type of insurance you have. We only have a half hour for this podcast. That would take a full day.
Okay. But you think it should cover insurance?
Absolutely, for the reasons that I just told you. If you look at the big picture and not just one moment in time, rehabilitation will improve outcomes and ultimately, I believe, will cut down on overall costs. But you have to look at the big picture.
Also by reducing the incidence of complications for which the insurance will have to pay. Bed sores, urinary tract infection. Rehab includes all of that. So if you add all of that, it will be more than
exactly right. And again, I go back to the example in the hospital when we provide aggressive therapies to people in the intensive care unit and the medical surgical units. They're mobile. They're not getting pressure sores. They're breathing better. They're getting out of the hospital faster, so they're not getting those hospital-acquired conditions. And we keep them out of the hospital.
So there are studies that show that this will save money even to the insurance. That if we are aggressive with rehab while inpatient or early at home, it will help.
Yes.
What do you say to caregivers? So it's not one patient, but two patients. When that patient goes home, the other person also needs care and support. So he's also or she also is a patient in a way that they don't get that recognition, don't get that support. So what would you say? And what do you do for caregivers? Do you have a course? Do you have a leaflet, a booklet, or social service? Who for weeks on end in hospital, the wife, the father, the son, they're outside. So what support have you developed and how important is it?
Yeah, so important. And I think you hit on it, that when someone has a severe disability, let's say when someone has a spinal cord injury or traumatic brain injury, it just doesn't affect that patient. It affects their whole family unit. So we bring them into their therapies. We want them to be part of the rehabilitation team so they feel that they're a part of that. We also educate them. This is what to expect, so that when they go home, they're not surprised. Nobody told me this was going to happen. But we also provide support. My social worker at NYU Langone Rusk has support groups for family members. There's the Brain Injury Association of New York State that provides this level of support. So many different ways in which we can provide education and
there's
support.
There's a phone number somebody can ring for support.
Absolutely.
So last few questions. What about professional caregivers? So as we have an aging population in India, and we find, and children are out there, some parts of the world, many in America, how do we look after these seniors and this shortage, acute shortage of professional and family caregivers? How should we address that?
That is a great question and not such an easy one to answer, in all honesty. There are not enough physiatrists in our country to address the number of people with disabilities. I'm sure that's the same in India. I think some of it's going to be what we call advanced practice providers, nurse practitioners, and physician assistants that we have. Telemedicine will help because then we can reach people who are not located or regionally close to us. So we have to be thoughtful how we do that. We probably need more physicians and more healthcare providers. That's going to be an expense that I think we'll have to somehow address, not just in the United States, but probably worldwide.
Thank you. And so we have to acknowledge the role of professional caregivers. These are not family members they're looking after, but 24/7 to look after their bowel, their bladder, their mobility. It's a really, really tough job. So what would you say to somebody entering this field? Would you encourage them to enter this field of rehabilitation medicine to these young trainees? What would you say to them? To get out of this field, or would you say, come on, join us?
I think the field of rehabilitation medicine is truly expanding. We touch every medical specialty, as I said, and everybody in their life at some point or another becomes disabled. It may be temporary disability related to an injury, let's say a broken bone, or a permanent disability, as may occur in a spinal cord injury, stroke, or traumatic brain injury. And that's what we do. And as the population ages, the role of physiatrists becomes even more important.
How important is assistive technology? So for us, this is assistive technology. For somebody who'll be hearing it, but people with major disabilities, is there integration in your rehab service of assistive devices?
So assistive devices, which can be very basic to highly complex, are one of the tools that we use to improve function and help people become independent. I think one of the great futures of rehabilitation medicine and a neuro rehab is technology in the form of neuromodulation, brain-computer interfaces, and how that brings in artificial intelligence and machine learning. I think that's the future, and will help improve motor recovery and improve function. We have a long ways to go, but that's where a lot of the research and excitement is right now.
Oh, thank you. And finally, your trip to Apollo Hospital. We've been trying to promote neuro rehabilitation here. We've got the robotics. What was your impression of the little time you spent with our therapists here?
So you have a very dedicated, very intelligent, well-informed group of therapists who take on complex cases, think outside of the box, and their outcomes in some very challenging cases are impressive. So kudos to Apollo Hospital. Kudos to you for bringing these very talented people in. It's very impressive and motivating even to me as a healthcare provider to see what you've done. So keep it up.
We have 10,000 beds and there are multiple centers that are treating these strokes, head injuries. Is there a role for somehow integrating this data, and would it be useful that we say, right, we'll have some uniform SOPs, operating procedures and recording, and would that really help research and others, do you think?
Well, I think
should we all work individually, do our own thing?
So it's a combination of both. I do think having some standardized measure of outcomes is important because that's how we measure success and the effectiveness of what we do. But rehabilitation is very individualized. So you can't say this is the protocol of how you treat somebody with stroke because everybody with a stroke is different. And you can go on down the line. But the outcome measures are important. And we're advancing that in the United States now using things like patient-reported outcomes because honestly, what matters to the patient should what matters most.
So we will do that, but it's been great having you, Steve. And I hope you come back again and you can see how we have evolved in our rehab journey. Thank you so much.
Well, Raj, thank you so much for having me. It's been an honor and a pleasure.